and welcome our guests online as well. We're very pleased today to have Dr. Catherine Ettman with us. Dr. Ettman is an assistant professor in the Department of Health Policy and Management at the Johns Hopkins University Bloomberg School of Public Health. Not a real good school, but you know. I like the tease, but her work explores trends in population mental health and policies across sectors that can improve health. She is the co-editor of Urban Health and Migration in Health. She received her PhD in Health Services Research at Brown University School of Public Health and studied public policy at Princeton University. Her talk today is entitled Population Mental Health Assets and Policy, Leveraging Longitudinal Survey and Electronic Health Data to Understand Drivers of Population Health. I think Salma asked me to give you a hard time, but I think, I'm going to leave that alone for now. She'll probably do it during questioning. But we're very pleased to have you here today and look forward to your talk.
Thank you for having me. Well, good afternoon. Thank you so much for having me. It's an honor to be here. My name is Catherine Ettman. I'm from the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. And today I will be presenting on population mental health, assets and policies. And I'll be sharing data, leveraging longitudinal survey data, electronic health data, and others to understand drivers of population health. So first, I come from a background in politics, and I'm interested in policies that shape assets that promote health, that can improve population mental health. So before I dive into my talk, I want to say, why study population mental health? Well, I'll give you three reasons among many. The first is that poor mental health is very common. Depression, as one example, is the leading cause of disability globally. Number two is that poor mental health is costly. It is estimated that depression and anxiety disorders alone cost around $1 trillion annually to the global economy. And third, the effects of poor mental health can stay with populations for a long time. And these are just three reasons as to why population mental health is of interest to me, hopefully to you as well. So this is a roadmap for my discussion today. First, I will discuss trends in population mental health. We'll talk about trends leading up to the COVID-19 pandemic, and then trends that our team has found after the pandemic. Second, I will discuss the important role of assets in shaping health. And third, we will talk about some potential policy solutions that we're particularly excited about that could improve mental health. So first, I wanted to share some context so that we could understand the trends before the COVID-19 pandemic. I guess we'll look at this monitor for now. It's fixed. And I just think it's fair to understand where we were as a country before we had this major stressor. Yeah, that's not good for your mental health. So first, briefly going into the pandemic, I just want to highlight there was this U-shaped curve of poor mental health by age, which will show where younger people were healthier. As you'll see, the pandemic bucked those trends. Second, depression and anxiety were increasing in the years leading up to the pandemic. I think it's important to be honest about that. And third, poor mental health was increasing more rapidly among younger groups. Again, this was even before the COVID-19 pandemic. So just very briefly, before the COVID-19 pandemic, there was this well-established upside down U-shaped curve between age and depression, whereby younger age and oldest age had the best mental health. This is for depression in particular, and depression was highest at that midlife stage. Sadly, these trends have been bucked, but this was leading into the pandemic, our understanding of mental health. Now, second, there were increases in both depression and anxiety in the years leading up to the pandemic. Here, this figure is from 2015 to 2019, showing the prevalence of past year depression increasing over time. However, it wasn't increasing at the same rate for all groups. We actually saw that it was increasing faster for younger age groups. And this was, again, leading up to the pandemic. The same was true also of anxiety. And For anxiety, we saw even faster increases in anxiety for that youngest age group relative to older age groups. So I think it's just important to understand the context that people were living in and our health assets before we led into this traumatic experience. So enter the pandemic, which was a major life stressor. This is the photo of the Fiedler statue in Boston, where I was living at the time. I was going for a run along the Charles River when we decided we have to measure mental health. We have to understand what is happening in response to the economic disruption that we are seeing from the COVID-19 pandemic. And I feel very grateful that along with collaborators, many of whom are in this room, we were able to get funding to launch a national study. It was initially a 1-year cohort. All said and done, we are thankful to have funding for an 8-year longitudinal study. And in that moment, we decided we needed to understand how mental health was evolving, people's economic situation, and over time, we've now evolved. And the study also measures policy preferences. You'll see there's a blue bar on the left. I do that when I have a slide that's about methods. So the title of my talk also includes the data type. So I'm just going to highlight how we've learned about different trends using different data sources. So the first data source I'll share is the nationally representative longitudinal cohort that our team started. This is conducted in partnership with NORC at the University of Chicago. They have a standing panel. It's called the AmeriSpeak panel. It is representative of U.S. adults. They have multi-stage address-based recruitment. They really have state-of-the-art, highest standards for survey methodology in the field, and we are grateful to work with them. As I mentioned, this turned into an 8-year longitudinal cohort. We actually just completed our 6th year of data collection last Thursday. So we're really excited to get those data back soon. Our initial cohort was 1,470 people. We had a replenishment sample in 2023 where we doubled our sample size. And as you can see, we have about a steady state of about 2,000 participants who respond now every year. And because mental health is sensitive to the seasons, we're happier when the weather gets better, sadder in the winter. It was important that we go to the field at the same set of weeks every single year. So we were only in the field in March and April of every year to ensure that the trends we're picking up on are true changes over time and not due to variation by season. And I will make a note that we are very grateful to our funders. The first year was funded by the Rockefeller Foundation, and in subsequent years, this has been funded by the Beaumont Foundation. And we have 2 more years of committed funding, and we hope to have more after that. So the CLIMB study is an original questionnaire, but we based it off of validated screeners. For example, we used the Patient Health Questionnaire 9, the GAD-7 for anxiety, PTSD-5, etc., in order to measure mental health. We also wanted to have detailed measures of assets. So we took the best surveys that we could find across the country to measure wealth in different ways at the household and individual level. The whole second part of my talk is about assets. What do we mean by that? But the study was designed to capture very granular levels of financial, physical, and social assets. And last, we did have detailed stressors, for example, job loss, death of a loved one, eviction, and other stressors that people face. So I'm going to show a series of papers that we published and just highlight some of the major trends that emerged at the beginning of the pandemic and now that have sustained over time. So this is the first paper from this study where we found a 3-fold higher reporting of depressive symptoms during the COVID-19 pandemic relative to before it. So we looked at self-reported depressive symptoms, looking at that validated screener of 10 or more. We used our CLIMB data, that's the lighter green bar, and the darker green bar for the pre-pandemic period. That was from the NHANES study collected by the CDC. So we used the most recently available nationally representative data to understand how population trends differed. And you can see here, we found a rightward shift in depressive symptoms. So on the left-hand bar, 0, that's the people who are reporting no symptoms of depression, whereas 27, those are the people reporting all of the symptoms of depression and having them very frequently. And you can see that we had fewer people reporting no symptoms of depression and more people reporting more severe depression at the start of the COVID-19 pandemic. Now, this is a longitudinal study, so we've been able to track this group over time. This shows the next year, this is spring of 2021. The lighter gray bar, this is that enhanced CDC data. So that's pre-pandemic. You can see much higher number of people not having any symptoms of depression. The light blue bar was the first year of the pandemic. The dark blue bar was the second year of the pandemic. And as you can see, even through 2021, there was a sustained elevated level of higher prevalence of depressive symptoms. And this was true not only in depression, but also in anxiety. So this is a study where we looked at anxiety over time. Here we go through spring of 2022. And we did see a slight decrease in the prevalence of anxiety from 2020 and 2021 to 2022. It went down from 24.4% to 21.3%. But as you can tell, that is still a very high proportion of the population to be reporting symptoms of anxiety. Now I'll share some findings from another national study, and this was conducted in partnership with Facebook. And this study was a cross-sectional serial study that was run for 810 consecutive days. It was done in partnership between Facebook and Carnegie Mellon, along with some partners at Hopkins and University of Maryland. Our larger sample had 21 million responses during the period. In October of 2020, they were able to add some questions around sociodemographics that we've used for later analyses. So our smaller sample humbly has 11 million responses. And this is another set of data that we've used to track changes in depression and anxiety over time. So here you can see a figure that tracks self-reported symptoms of depression and anxiety. Anxiety is slightly higher when you use a one-item screener, as you can see. And there is some variation over time. Some of this does relate to spikes of the pandemic. But the main takeaway is that we've seen a sustained elevated reporting of depressive symptoms here all the way through June of 2022. So this is 2 years after the start of the pandemic. We were seeing really sustained levels of poor mental health. And at the beginning of my talk, I said pre-pandemic, we did see some age stratification. The same is true during the pandemic. So I'll highlight just the left top quadrant. So here you can see levels of depression over time by age group. And sure enough, we see that people who are younger were more likely to be reporting poor symptoms of depression at any time point relative to people who were older. So we did see that this was sustained through the pandemic, and perhaps it was feeding on those trends that we saw earlier, where younger people were more likely to be reporting poor depression and poor anxiety at a faster rate than older people. Now, this wasn't just our work. We did conduct a systematic review where we analyzed all studies published about depression during the COVID-19 pandemic through April of 2021. And for this, we identified 49 articles. So this was not just ours contributed to this, but there were many others. And for this, we did find that these elevated levels of depression across time were sustained, and these were also found across different screenings. And now third, I'm going to focus on trends in access to mental health care. So we know that there were elevated levels of people reporting depressive symptoms and anxiety symptoms during the COVID-19 pandemic. So how did the healthcare system respond in order to treat these populations? Now, for this study, I'm going to highlight data from electronic health records in Johns Hopkins Health System. We have a cohort of patients with depression at Johns Hopkins, and our records are reliable from around July of 2016 onwards. That's when the Hopkins system implemented Epic, their electronic health records. We have around 300,000 patients within the cohort. And for this study, we wanted to understand trends in mental health services utilization over time by telehealth use. And one reason I love this graph is I think this graph should be on every wall of every hospital, because it shows the success of the healthcare system to respond to this unprecedented event and to provide health services very rapidly. I mean, relatively speaking, in the context of this event, to be able to go back to the sustained levels of care almost within several weeks through the use of telehealth to me is extraordinary. And just to show the numbers of appointments that changed before the COVID-19 pandemic, so before March of 2020, Hopkins had 97 appointments in its EHR conducted via telehealth for mental health. In the year after, it had 203,000 appointments conducted via telehealth for mental health. So you'll see later on, we do kind of beat up on the health system because we're saying, oh, inequities have emerged. But I don't want to lose sight of the main message that the health system really did respond well. It pivoted so quickly. And telehealth was able to meet the needs of our populations, particularly for mental health status. And it's interesting to look at these trends for mental health care versus other healthcare over time. We have seen that the modal form of care is now going back in person, which is probably appropriate, particularly for somatic issues where you'd want a physician to see you in person. But for mental health, we're still seeing that telehealth is a modal form of care, which means that it may be an appropriate way for some populations to deliver mental health care. So this wraps up the first part of my talk on trends in mental health. So just to summarize the trends that we saw post-pandemic. First, our team contributed to the growing evidence that there was elevated, sustained levels of depression and anxiety at the start of the pandemic that were sustained over time, up to 3 years post-pandemic. Second, we did see the reversal of that U-shaped curve for protection of age, where being younger was now a risk factor for mental health instead of being protective. I think is kind of somewhat problematic for society, but something for us to keep in mind. And third, I wanted to highlight the rapid increase in the use of telehealth. And so there is a lot of excitement around the potential of telehealth, but as you'll see later on, we also want to understand what some of those pitfalls are. So now we're going to talk about how these trends differ across economic groups. I mentioned at the start of my talk, I'm interested in assets. And there are 3 frameworks that really shape my thinking on how assets shape mental health. And so I wanted to share those 3 frameworks. So the first is one that everyone is probably familiar with. This is a social ecological model that's built on Roth and Brenner's work, where we understand that the individual is in response to their context. So their health is the product of not only their personal and genetic features, but also, and potentially more importantly, the home environment, their context, the neighborhood, which is also part of the state level policy environment, which is also part of the national and even international policy environment. So this, number 1, informs our thinking. Number 2 is cumulative inequality theory. So in this theory, disadvantage accrues to people faster over time who have less to begin with. So in this toy example, there is Adam on the top and then Eve on the bottom. So you can see when they are born, there is an initial gap in the health between Adam and Eve. Because Adam is born into more privilege, he accumulates disadvantage at a slower rate than Eve. So you can see that over the life course, Eve is accumulating these stressors and these challenges for her health such that at the end of the life course, they have a wider gap than when they started. So this is called the cumulative inequality theory. Another phrase for this is the Matthew effect. And this comes actually from the Bible, from Matthew 25:29, which says, "For unto everyone that hath shall be given, and he shall have abundance. But from him that hath not shall be taken away even that which he hath." So in modern terms, we might say the rich get richer and the poor get poorer. So we are unfortunately testing this and seeing this in our data, but this informs our thinking. And last, the third framework that shapes our thinking is the assets framework for population health. This is from a paper that I published with Dean Galea. And in this framework, we identified 3 types of assets that shape access to health promoting resources: financial assets, physical assets, and social assets. So for financial assets, yes, we mean income. So often in the United States, when we talk about economic inequality, we often talk about income inequality. Well, income inequality is important and it is a piece of the puzzle, but it is only one piece. So for example, if you're interested in differences between white families and Black families, if we look at income differences, those differences are 2 to 1 for income. If we are interested in wealth differences between white and Black families in America, those gaps are 6 to 1. So one reason that we think it's important to look more holistically at different types of financial assets that include wealth and different types of assets is to understand, number one, where are those true gaps growing in wealth, more so even than income? And number two, what are some policy interventions that we can use to get creative in trying to address these different assets? So there may be a policy route that's been long trodden around income, for example, and perhaps we don't think it's so successful to keep going down that route. Well, we have an opportunity to bolster assets by looking at a range of other financial assets. So in our work, as you'll see, we look at savings, we look at debt, we look at credit, and these are all parts of a person's financial stability. We also look at financial assets. Those include home ownership. Eventually, they'll also consider auto ownership, and also physical assets such as devices that allow you to reach your doctor or economic opportunities, as well as Wi-Fi and resources that allow you to, again, take advantage of both economic and resources. And then finally, we have social assets. So those include educational attainment, marital status, and also religious affiliation. So these are the social bonds that provide social support, but that can also provide material support, and also privilege and access in society that can have health promoting benefits. So before the COVID-19 pandemic, our team wanted to understand whether there was a difference in savings across depressive symptoms. And in this study, we used the NHANES data from the CDC. And you can see on the x-axis different income groups. On the y-axis, you can see depressive symptoms. Now, the colors represent high and low wealth groups. So the darker bar represents families with more than $20,000 in savings. And the dashed line represents families with less than $20,000 in savings. And what we found in this study was people with less than $20,000 in savings had 1.5 times the odds of reporting depressive symptoms, even when controlling for income group. And I think this figure shows it really well, where even in this highest group, the people making more than $75,000 a year, even they had a differential odds of depressive symptoms based on their savings profile. So we're trying to complicate the notion that income alone is determining a person or a family's financial stability. Now, during the COVID-19 pandemic, there was sadly no group that was spared the ill mental health effects of the pandemic. However, we did see that groups who had fewer assets were more likely to be reporting depressive symptoms, and those groups were also more likely to experience stressors that could harm their mental health. So in this figure, we show depressive symptoms over time. So this is having multiple presence of depressive symptoms more than 1 year. And you can see financial assets, physical assets, and social assets. There is a gradient. It was significant for our financial assets. So you can see almost a dose-response relationship where people who have higher assets financially are less likely to be reporting depressive symptoms. Now, in another study, we looked at 3 years of data, actually 4 years of data, and we used generalized estimating equations to pool over time within an individual to look at savings, income, debt, and financial stressors. When we controlled for all financial assets at the same time and financial stressors, we found that having higher savings was still protective. It was significantly associated with lower depression, but that income association goes away when you control for savings and debt. And financial stressors still remain significant as well. In another study, we tried to understand the difference between who owns the assets. Many national surveys ask about household income or household level financial assets. In the CLIMB study, we specifically asked about household income and savings, but also individual income and savings. And this is based on theories of autonomy and locus of control, that perhaps your house has a certain income, but if you can't access those funds, you don't have the same mental health benefit. So when we look at each of these, household income versus individual, my income, when you look at them individually, they're each associated with poor mental health, or having more is associated with less mental health. That makes sense. And if you're running a study and you can only pick one of them, at least it's better than none. However, if you put them all together in the same model, so we're trying to adjust for your household situation while looking at your individual savings, what we found was that for anxiety, individual level income and savings were associated with improved mental health, whereas those household level, they were not anymore. And so this provides evidence against what we would call the unitary household theory, whereby we're assuming that everyone in that house has the same access to those resources. So to us, this suggests that maybe they don't. Maybe certain individuals have more control over their finances, which can then bestow improved mental health, which obviously has implications for policy-directed work. Here we looked at anxiety and depression by savings groups over time. On the left, we have anxiety. On the right, we have depression, and these are our savings groups. As you can tell here again, we have people who had more savings, had much lower depression. People who had fewer savings had more depression and more anxiety. And finally, this is the last piece of data that I'll show from the CLIMB study, and then I'll show some of our assets work using other data sets. Here, we tried to look at different parts of America, what I had called the four Americas. So again, we would typically think of high income versus low income groups, but we wanted to complicate that and say, well, what about people who have high income but low savings? And what about people who have low income and high savings? And so in this figure, we show those four separate groups: people who have low savings and low income. As expected, they had the worst levels of depression over time. Then we looked at people with high income and high savings. That's that red bar. As expected, they had the lowest levels of depression over time. But then you have these dissonant groups where either they have high income and low savings, or low income and high savings. So what did we find? And I think this is the most interesting, is that light blue bar. So this is the group of high income individuals who you would usually lump in our surveys to say they're doing well. The group with high income and low savings was the only group to see their mental health get worse over the COVID-19 pandemic. So this, you can notice all of the other ones are going down or staying the same. So things are getting better, stressors are being relieved. In that group, their mental health got worse as time went on. So who's in that group? Well, people who have jobs, who have high expenses. This group was parents. So people in mid-age, people who have high expenses, young children. So again, this is complicating our idea that income is the only driver of economic disparities for mental health. All right, so now we're going to look at some of our other studies. So this is going back to that big Facebook study that we talked about. And I just wanted to show that financial stability is so important that even when we go into studies looking for something else, this is what always comes up. So in our Facebook study, we had originally wanted to look at the influence of schooling policy on parental mental health, whether schools were in person or fully online or hybrid. We found some modest effect estimates where families whose children were at school in online, they had worse mental health than the people whose children went back to school. But do you see what mattered way more than anything else? Financial strain. So even though we went into the study trying to look at these peach bars, the real story was the blue bar, which is actually, regardless of the schooling modality, a family's financial stability was the largest driver of mental health within that family. And this is intimately tied with stressors. This is a study conducted by Dr. Abdallah, where you can see the different types of stressors that are associated with higher levels of PTSS and anxiety. The same is also true of depression. So you can see here the the highest reported stressors were family problems, loneliness, having difficulty paying rent, losing a job. So all of these were associated with worse mental health. Another claim study snuck back in, but it's a good one, so I'll keep it. So this is just to highlight the fact that people who had fewer assets were more likely to be experiencing stressors. So we know from the literature that job loss is associated with poor health outcomes. And unfortunately, the families that had fewer assets going into the pandemic were the ones more likely to experience stressors. They were more likely to lose their job. So we call this the double jeopardy, more likely to have these health effects, such that we had an interactive effect where even when you control for all of their factors, there's a fourfold difference between the families who had wealth going into the pandemic. They did not have stressors versus the people who had no wealth and had many stressors. So again, we're seeing these cumulative inequalities grow. In this study, we used Pew data to look at the effect of job loss over time. So here we use propensity scores to balance the group of people who did and did not lose their jobs at the start of the COVID-19 pandemic. And we did find a significant effect 27 months after that job loss. So this just goes to show that those cumulative stressors do add up over time and they stick with people, which is concerning. And in this study, we tried to understand, well, does having assets help? Like, have some savings? Does that buffer some of those ill mental health effects of stressors like job loss? And here you can see that we use education as the asset. People who had more education, they had less depression than people who had less education. However, we didn't find a significant interaction between stressors and assets. So that could either be sample size or that stressors are stressful. And so even if you do have assets, like they can't protect fully against the stressors of job loss and other life events. And again, I wanted to make sure that this wasn't just our group's work. So we did another systematic review where we looked at assets and mental health across the COVID-19 pandemic. And we found consistent findings across studies where higher income was associated with less depression, consistently in 88% of studies published during this time. Marriage was protective in 72% of studies, and owning your home was protective in 100% of studies. So this is the strength of assets. So now I'm going to talk about another asset that I'm pretty excited about. So this is some of our new work, and we're interested in credit scores. So credit scores are one measure of access to capital. And in a universe where we're thinking about assets, credit is a gateway to accessing assets. Credit scores can influence, for example, the ability to get a job, your ability to rent an apartment, or the amount that you have to put down for a security deposit, and how much one pays for loans, ranging from auto loans to house loans. So credit scores are important. They're also a nice one single longitudinal number that tell us about a person's financial stability or their financial savvy, right? Because some families know to give their kids credit cards at 18 and pay them off every month so that they can have great credit by the time they're 30, and others don't. Or worse, some families might put their children on their credit and then not pay those bills, and those kids have to inherit that debt. So there are three main credit agencies that rate consumer credit. Lower credit scores are worse credit. Higher credit scores indicate lower risk for lenders. So that's why they get preferential rates. They get lower prices for loans and easier access to capital. You can kind of see the theme in my talk, this cumulative inequality, where the rich get richer, they get better rates, they have to pay less, and poor get poorer. So in this study, we used our CGIS data. Again, those are those Facebook data. We subset just to the state of Pennsylvania. We looked at individual level self-reported mental health, and we looked at area level credit scores. So we looked at 438 zip codes in Pennsylvania. We were able to acquire credit scores from Equifax. And in this study, we wanted to look at a multi-level model, the association between living in an area with poor credit scores and mental health. Now, the first thing that people tell me is like, well, doesn't that just tell you about their income? And we wanted to show them, no, it's something different. So in this figure, we have three models. So the first model is the unadjusted model, simply looking at area level credit scores and individual mental health. Boom, you can see a really high effect estimate, where again, the higher the credit score of the area, the lower the prevalence of mental health. we understood, we expected that it would be in the unadjusted model. But then the next two colors are adjusted model. So this green one is when we're adjusting for features of the environment and the individual, race, gender, age, composition of the neighborhood. And then finally, this orange circle shows when we control for area level median income. So now we are adjusting for income, and even when we're controlling for other economic factors, credit scores are still significantly associated at the area level with individual mental health. So this is one of the first studies in the country that's looking at credit scores with mental health. We have a few other ones in the works, but those are really preliminary data. And it says in press, but I got the email today from ABC, that they published the final version. So you can find it online if you're interested. And then last, to close the conversation about treatment, to say we understand that people have higher need for mental health treatment. Are they receiving it? Well, let's go back to our electronic medical records. And here we're trying to understand whether all of our patients are able to get that added benefit of telehealth or only some. And as a proxy for economic status, in these data, we're using area deprivation index, where the higher the ADI, that means the worse economic status within that area. So it's a combination of things like median household income, housing quality, et cetera, from the American Community Survey. In this study, we used 2021 area deprivation scores. We created 3 groups, so people who are living in high deprivation areas, medium, and low deprivation areas. We link them to our EHR data, and I'll show you 2 separate studies. So first, we looked at completion of care across different groups, and we did find that patients who lived in areas with worse deprivation were less likely to complete their appointments, more likely to no-show. So there's something happening there. And then in this next study, we wanted to understand trends in telehealth and whether telehealth was improving access to care, as we all hope, or if it was potentially leading to increasing gaps in access to care across economic groups. So what this study shows is, or this figure shows the percentage of mental health care being received by telehealth by area deprivation. And what we found is a clear delineation where the wealthier the neighborhood that our patients lived in, the more likely they were to use telehealth. And the poorer the area that our patients came from, the less likely they were to use telehealth. So what does this tell us? Well, it's possible that while telehealth reduces some barriers to care, like needing transportation, getting to the physical office, it might be raising new barriers to care, like needing a private room, needing stable Wi-Fi, needing to be able to get the time to take a telehealth call. And such that these trends are leading to differential access to mental health care, where actually we found that patients living in wealthier areas had on average more mental health appointments post-pandemic than they did pre-pandemic, whereas our patients who are from higher deprivation areas, lower wealth places, they had the same number of average appointments. So actually we are finding evidence of an increasing gap in access to care based on area deprivation. And it is possible that telehealth may be contributing to that. And then in this figure, we just looked at interactions over time to understand, was this trend changing over time? And unfortunately, we are seeing that gap is growing over time. So it's possible that over time, patients are sorting into telehealth who have greater wealth and therefore maybe are seen a little bit more frequently than our patients who aren't. So to conclude this section on assets and mental health in summary, number 1, assets matter for mental health. Number 2, wealth outside of income alone is associated with, actually, I should say, having more wealth is associated with improved mental health. Having less wealth is associated with poor mental health. And number 3, new technologies like telehealth. There may be some promise, but they may also be widening some of those treatment gaps across different asset groups. So now we'll just go to the third part of the talk, and then I'd love to have Q&A with the audience. So not all hope is lost. We do believe in the power of policy to change access to the world that we we live in, so that we can improve mental health. So here are some ways that we're thinking about how policies can shape mental health. This is a framework that we've adapted that looks at the intersection of public opinion and strength of evidence. So on the x-axis, we have strength of evidence. So what did the data show around these associations or causal relationships? And then on the y-axis, we have strength of values. So what does the public think about this? And now I've created an example specifically for mental health, and we'll go through some of these. So let's use this top right quadrant. So this is mental health insurance parity. So there's a lot of evidence that when you pay for people's health care, they use it. And that's true for somatic health. That's true for mental health as well. And people generally support mental health care. Like, people think that you should pay for mental health at the same rate or no worse than what you would pay for physical health. So this is a nice example where we've got loads of evidence and the public is in agreement, like we should pay for mental health care. Now, in contrast, in this quadrant, we have strong evidence, but low public support. And here I use the example of harm reduction for substance use. So there's a lot of evidence that harm reduction strategies work to reduce things like the transmission of HIV, to reduce unintended death. However, there is low public support, and we use the example of Philadelphia, which passed a policy to have a safe injection site. This was for public health. However, public support was so low that it ended up going to the courts. And long story short, they had to close down the safe injection site. So this is an example of even when you have all of the evidence, if the public is not on board, a policy might not pass. And even if it does, it can be taken away. So now we'll look at the other quadrant. So up in this quadrant, we've got a lot of excitement, but not much evidence. And I put mobile app interventions here, some work, but the evidence is pretty mixed that a lot of mobile apps, which have billions of dollars in investments, like they don't necessarily change mental health. They're not getting at the structural drivers. They're just band-aid and they don't work in most cases. And then in the bottom left-hand quadrant, this is where I'm trying to build out our evidence. So here I put financial well-being. I think it's a space where we're building the evidence. So for example, in wealth, there really is not as robust of a literature as you would hope around non-income financial assets and how they relate to mental health. And my hope is that by looking beyond income, there's also like very little public sentiment. Like right now, I think the public doesn't really have strong feelings about credit score policies. So my hope is that we can take advantage of some of those areas to create policies that the public can support, where we can lead with the bipartisan nature of mental health and the areas where we can come together to change policy. So Dr. Ruth Shim, in a commentary in response to one of our papers, said that to effectively prepare to face public health crises, we need to commit to addressing the social determinants of health. We know from the data that investments in public health and social welfare over investment in health services will achieve better health outcomes. So we thought this was really inspiring. And one way that we are trying to continue the policy conversation is by hosting convenings. So we actually were able to bring Dr. Ruth Shim to Washington, D.C. 2 months ago with a bipartisan panel. So we've got someone from AEI, we've got NAMI represented, Dr. Shim, and then a representative from the foundation world, to talk about bipartisan policy solutions of what are the areas where we can come together, particularly on mental health. So I'm really hopeful that we can foster these conversations to look at the evidence and also shape public opinion to make it a favorable context for policies to pass. This is just one piece of evidence where non-health policies can shape health outcomes. So just one example of unemployment insurance benefits. So for households that do receive more generous unemployment after that stressor of job loss, they do have reduced depressive symptoms relative to families who have less generous unemployment policies. So this is just one example of a non-health policy that we can try to pass collectively to improve health. So I know at the beginning of my talk, I talked about how Adam and Eve, the gap was widening, but it doesn't have to be that way. We can also close the gap. So there is another world in which we intervene, where we have policies that try to close the gap in assets and the gap in health outcomes, and actually some wicked smart researchers have done simulation modeling to say, hey, look, if we do nothing, these gaps are going to get wider. But if we do something, if we pass some of these policies to close the wealth gap, we can actually close the income gap completely in 100 years. And we can get that wealth gap down to almost 2, which would be much better than where it is right now at 6. So these are just 3 policies that I'm really excited about right now, and I'm glad to be speaking with some collaborators here in the room later today about how we can push these forward. So one is thinking about credit score policies, removal of medical debt as one example of a way to help increase credit scores. I'm happy to talk about credit score policies with anyone who's interested. Another is baby bonds. So we're quite keen to think about how early investments in childhood, particularly for low-income Americans, can then lead to an asset for wealth generation over time that can protect not only them, but also their families. So there's great work that was done here at WashU over many years, Dr. Stratton and others who have shown that investing in families early in life can have health dividends for families across the life course. And then last, our hope in this current moment, while there is a lot of disruption to the social safety net, is that perhaps we can simplify the social safety net, or perhaps we can build it back in a way that is better. So in conclusion, I want to highlight the public health successes. So Dr. Josh Sharfstein has written that we need to do a better job as public health professionals of singing our successes. And so here are some of our successes. We've reduced lung cancer collectively as a field. We've improved birth outcomes. We've lowered motor vehicle deaths. We've reduced lead poisoning and extended longevity. Well, how did we do that? Collectively, we did that through policy, through indoor smoking bans, through folic acid fortification, vehicle safety standards, removing lead from gas, and much more to come. So we have done this before, which means we can do it again. And I'm really grateful to be in this room to discuss your work and where we go from here. I just want to say thank you to the many people who contribute to this work, as well as my funders who make this all possible. And thank you for having me.
Questions?
Thank you so much. That was really fascinating. I have lots of questions. I'm going to start with just one. I wondered, in your household savings and income studies, if there's any ceiling for savings, like there is sometimes with income beyond meeting your minimum needs to survive. You know, is there a savings? Like if you get here, you're good, or is it linear?
It's a great question, and we struggle with this every day as my analysts are like, what trade-off should we use? What's most important? Is it 2,000, 5,000, 10,000, 100,000? One challenge is that wealth is so unequally distributed in the country that we kind of have to make some sacrifices when we're doing our analyses in order to make sure we have large enough sample size. So we have, like, if I were to show you the histogram of savings by Americans, it's completely bimodal. Like 30% of Americans have no savings, then another 30% have over 100K in savings. So these are really different experiences. And then you have the middle. So we're trying to figure out the best modeling strategies for that. So the CLIMB study is one of the few studies in the country that has savings across the whole age cohort. So for example, the Health and Retirement Survey, they have some nice, robust savings data, but it's only for older Americans. So we are limited, but this is my hope in using these creative data sources, like working with credit agencies or working with banks to try to get larger sample sizes so that we can get more granular. But for now, we're trying to understand what cutoffs matter. And I hope it's something we can do more of in the future. So thank you for asking.
When you're looking at income relationship to depression, do you take into account previous instances of depression or anxiety, or is it all new incidents of depression and anxiety?
We've done it all. So it depends on the research question. The single biggest predictor of a future depressive episode is having ever had a depressive episode, which to me is really concerning when we see these younger groups reporting depressive symptoms, because now they've had an initial depressive episode, they are at greater risk for the rest of their life for having future depressive episodes, regardless of their income. So I did want to flag that for us as a group, because I think we should all be aware that as this cohort ages, they're at kind of higher risk now that they've had this previous depression.
And is there any effect of depression or anxiety on income, right, as you go forward? So just,
so we have a study that is not published yet. So my mentors would tell me not to talk about those results, but I can say that it is a bidirectional relationship. So we have evidence that goes both ways, that like, yes, having lower income means that you're at greater risk of having initial depression, most likely because you're more likely to have like greater stressors in life, but also having poor mental health, it does lead to kind of income loss and even savings loss due to temporal discounting and decision making. We have another study that we're working on looking at like predatory financial devices. So we have a paper we're working on right now with buy now, pay later loans. And it does look like people who have poor mental health to begin with are more likely to be targeted and more likely to be using these financial tools that are just going to put them in a worse financial situation. So not good.
Go ahead.
Mine is a strange question maybe, but you highlighted some of the financial specific policies that are happening or being considered on Capitol Hill, but you also talked about the social and the physical assets. So what is the strategy to consider policy to address some of those outside of just the financial concerns, as you said at the beginning?
I love that question because that's the harder one, because that comes to value. I think physical assets are much easier to say, like probably all people should have safe housing. Probably all people should have transportation. I think we agree with that, but it's more difficult to say. And this is where we can challenge ourselves as a field to say like, well, maybe there are some values that overlap with certain conservative ideals. Like, for example, marital status does seem to confer some real mental health benefits. Now, that doesn't mean every marriage is high quality, and we understand that there are nuances there, but how do you create a policy around that? We have another paper right now, it's not out yet, where this doctoral student, he keeps running. We're looking at parent status, and she's like, parents are less depressed. And my colleague is like, well, what are we going to do? Tell people to have kids? Like, that's not the policy intervention. So we're challenging we are challenging ourselves to say like, well, what do the data tell us? And if marital status is protective of mental health, how can we give people the assets and the resources to make those decisions? Because people who are more likely to get married are more likely to have degrees and are more likely to have more stable jobs and employment. So I do wonder if there are ways that we can come together to say, okay, it is value-based, but let's use the data to inform it. And maybe we come at it from a different angle, but how do we give people choices to make the choices that will hopefully provide them with better mental health?
You can go. You have time? If not,
We
got one more question. So okay. You two can battle it out.
Yeah.
Oh, so you can ask them later.
Yeah.
I mean, this is pioneering research, of course, this health wealth connection. I've been working with Michael Sharadan for 30 years, and it's really pioneering graphs, fascinating. So the independent effect of assets on mental health is really interesting. I'm just curious for the theory on the mechanism. What is it about assets, do you think? And I'm interested to hear sort of your theory, how much it reflects what Sharadan talked about 40 years ago as well, or do you have some sense of what the mechanism might be? Because it might be unique in mental health field versus some of the other things that
Yeah, great question. So in another version of this talk, I have Dr. Sharadan's book, Assets and the Poor. And I say, this is the book that pivoted my dissertation. That when I read it, I was like, oh my gosh, it's brilliant. So he's definitely, he and his team have shaped a lot of how I think about social policy in America and how kind of not fair it is. In terms of the mechanism, I think there are a few potential hypotheses. So one is the ability to withstand life stressors. So I do think that having assets gives you more autonomy over your time, over your context. So if you lose your job, but you have savings, you can keep your house. You don't have to sell it. You can keep your routine. Like routine is actually really important for mental health, even when people have to change how they get to work. That shapes their mental health, like if they have to take a different road. So that's how creatures we are to habit. Whereas I think that if you have assets, you have a lot more autonomy over your habits and over your time and over the spaces that you exist in. And so you can kind of keep more stability as individual things change. And I'm sure, I think that there are ways the mechanisms are the same for somatic issues, but also different. I do think mental health is promising to look at the health wealth connection because it's like the bellwether of physical health to come. So it's going to take like 30 years for, diabetes to show up and heart disease, which we know through many's work in this room, that we do have these differentials. However, I think it just takes a lot longer to get there. Whereas for mental health, you can kind of see some immediate effects when you have job loss and you have income shocks. So I think mental health is really important to be kind of like the bellwether for the rest of population health.
So we got to stop. Thank you so much.
Thank you for having me.